So we're back now, and we're back to do our monthly medical slot with our resident pharmacist, James Geraghty, in studio. We'll introduce James's guest in a moment. But James, we're back to do something special this month.
Yes, Jerry. Thank you for having me. We're going to talk a bit about obesity.
Okay.
It's an area, I suppose, Jerry, that we haven't really touched on because it was so broad and so, I suppose, in many ways, so specific. But I have a wonderful guest here with us today, and we're going to have a general chat in relation to obesity. And I suppose to kick it off, Jerry.
So Sharon Egan, an advanced nurse practitioner. Good afternoon to you.
Good afternoon. Thank you for having me.
It's a pleasure to have you. So you're based in Bell.
Yes.
And how did you get into this whole area of obesity and weight loss and this part of medicine?
Well, I worked in cardiology for years, and when I moved back to Ireland in 2016, I was working in the ICU in Caspar, and I just seen that there was a huge opening for preventive cardiology. So I did my master's in preventive cardiology and my advanced nurse practitioner, and I specialise in cardiometabolic diseases and in women's health.
Wow.
And obesity falls between the two stools.
Very much ties in there. And James, it's timely we do it today, because you reminded me before we came back on air that tomorrow is World Obesity Day.
Yes, absolutely, Jerry. And I think, I took a little quote from their website, and it just says, people living with obesity deserve care free from stigma and shame. Yeah. And I think that's very, very important.
Says it all.
And it says it all. And just one of the little notes we got in, Jerry, I can just maybe read it out, and it'll encompass maybe an overview of what we're going to have a little chat about today.
Perfect.
So, dear Jerry and James, I am writing to you as I love the show and feel you might give me some answers. I am a 47-year-old lady with 2 teenage children and a busy family life. Over the years, I have had battles with my weight, and now we're in at 18.5 stone with a BMI of over 35. My doctor says I am pre-diabetic and my blood pressure is increasing, although I am on no medication. I cannot look at myself anymore, as I feel deep shame at who I have become, and I struggle around the house daily feeling a deep sense of guilt. I have tried all the diets but tend to go well, then I break out. I am now considering the injections that everybody is talking about. Are they okay to take? Are they safe? Do they work? What are the side effects? Any advice would be greatly appreciated. Yours, Anne.
Kind of says it all, really, doesn't it?
I think that's a very powerful overview in relation to where we are today, and even maybe just to kick off the discussion of what is obesity, Sharon?
Well,
where has it come from?
Actually, she explained that very well there in her letter. But obesity it's a complex chronic disease. It is actually progressive, so therefore the dieting you will always regain because it is a progressive disease. It is neuroendocrine in origin, but it is governed very much by our genetics, our biology and our environment. So it's a very complex disease.
Yeah.
Sharon, would it be fair to say that it's only in the last number of years that we've even termed a disease?
Yes.
Once upon a time people were just said, oh, they're fat or they're overweight or whatever it might be. It was never considered to be a disease.
It was never considered a disease, and it was always treated as eat less, move more. And that was never going to work. And that was just setting patients up for feeling ashamed and for failing.
And now there are certain people who be genetically predisposed to obesity.
Yeah, genetics is 50%.
50%.
Yeah. There was actually a very, very good saying or a good wording about it that said genetics is the ammunition in the gun and environment is the trigger that pulls it. Yeah. And I think that's a great analogy for obesity.
What about gender?
Gender, not really, no.
Roughly the same number of men as women, vice versa, affected.
Maybe more women will come forward for treatment than men, but genetically predisposed equally.
Yeah.
So we're both kind of cross-examining you now. It's like being in front of the 2 lawyers for James.
Well, I think purely from and I'll talk, just a little bit about myself, like my journey. As somebody who would been extremely slim in my 20s, and I started to actually gain weight. And from my own perspective, I can talk about the wonderful Paul Ginty, Orla Donnelly, Stephen Donnelly, all of these people, my physiotherapist and all of that. But the damage that the weight that I was gaining was really around not sleeping, diet or joint issues. And all of those, and my weight was not that much, maybe 2 to 3 stone. Yeah.
And you're a big man, you carry a big frame.
And people would say, "Oh, you can carry it, James. Don't worry about it." But for me personally, it was a really difficult journey for me. Now I feel through education and self-educating myself that I have a greater understanding of what I can and cannot do. Yeah. Now I know there was a couple of Mikado left on the plate out there this morning, and they've stayed there.
Oh, okay.
Learned, yes.
Well, that's a change. I don't mind saying.
Yes, I've learned to control that. But ultimately, I think there's another step, Sharon, down the line where people tend to lose that control, and then they're moving into greater weight, where they're struggling, as that lady said, coming down the stairs with weight, causing issues around joint, and the other areas around obesity where you get difficulties around diabetes, heart issues, and all of that.
Yeah. I think with obesity, it is now classified as a disease, and the comorbidities associated with your obesity is diabetes, cardiovascular disease, some cancers, joint pains, infertility. Like, there's so many comorbidities that treating this one disease of obesity could eliminate all those comorbidities.
Yeah.
So it'll improve health and it'll improve economics.
Absolutely. And ultimately, I suppose that leads us on to the discussion in relation to these amazing new medicines that have, just talking briefly beforehand, Sharon, we were mentioning there about the blue pill that we spoke about, Ger, the Viagra.
Yeah.
Statins, which are now very much common and part of people's lives. And even I was just talking to Sharon there, Jerry, about a new study that has come out about statins, about the excellence in relation to the low side effect profile that they actually have. And now we have these particular new injections. And just like a brief history of them, Sharon, like where did they come from? I mean, obviously diabetes was involved, and they noticed that they were improving
these
weight
new
loss.
incretins. So GLP-1s have been used maybe for the last 10 years.
What are GLP-1s, Sharon?
These are the medications. These are these new injectable medications. Okay. So we have their incretins is what they are. They're natural peptides in our body that has been mimicked and injected in to be used as a treatment. So GLP-1 has been available for a good few years for the use for diabetics, and they noticed that there was a benefit of weight loss with them. So the drug company, the initial, there was Victoza, there was Ozempic, there was a few of them. We'll say semaglutide just to be correct. So the drug company then, Novo Nordisk, developed another medication called Wegovy, which is the same drug, semaglutide. It's used in higher doses and it's used to treat diabetes. So then came along the dual agent. So that's your GLP-1 and your GIP. So that's your Mounjaro, which has huge efficacy as well in weight loss. So basically how they work is it's a once a week injection. And what they do is they slow down the peristalsis, so that's how your gut moves the food.
Through the system, yeah.
So that slows down your gastric emptying, so that makes you feel full for longer. But that also is what causes your side effects of maybe your nausea, constipation, diarrhea, GI disturbances.
GI being?
Gastrointestinal.
Okay.
Yeah. So then the important way how they work is that they cross into the blood, cross our blood-brain barrier and into the hypothalamus, which is the part of the brain we don't have control over. So that's the part of the brain that controls your appetite, your satiety, your cravings. So what they do is they lower the gremlin, which is your hunger hormone, they increase the leptin, which is your satiety hormone, and they create this balance. So you don't have cravings, you don't feel hungry. When you're having your dinner, let's say you will stop eating when you're full, you won't keep going because you feel you want to. And actually, these drugs are showing great potential in gambling, alcohol and drug abuse because they're reducing that craving.
That desire to have more. Can I go back again for a second to, at what point does one become obese?
Well, the clinical diagnosis, and you do have to have a clinical diagnosis, especially if you want to be prescribing medications. So what we use, I don't know if you can see it here.
I can.
I brought
Very
the
colourful
BMI
chart. Yeah.
And this is another one we use, the Edmonton staging tool.
Okay.
So your BMI is when you're obese. Obesity is in 3 stages.
Right.
Stage 1, 2 and 3. Obese stage 1 is your BMI is above 30. Obese stage 2 is your BMI is 35 to 39, and obese stage 3 is over 40. So based on that level of obesity and how you would score on the Edmonton staging tool, which is more holistic, brings in your psychological needs as well, then you would guide your treatment.
And that's different from male versus female, and I presume it's based on height, like James, a big man there, he's a big frame in him. Would his BMI be different to my BMI, because I'm not as big a man as James, or is it across the board?
BMI would be their BMI because it's based on your height and your weight.
But it is to the individual.
But it is to the individual. And what we would always do as well is waist circumference, because that's your visceral fat. So that's your cardiovascular risks. So the wider your waist circumference is, the more cardiovascular risk factors you'll have.
So is it fair to say the worst place to have weight is around your belly?
Absolutely, yeah, because it's pushing against all your organs. So you've got that thick visceral fat pushing against your pancreas, your kidney, your liver. So that is, the more visceral fat you have, the more cardiovascular risk you have.
And Sharon, may I ask, and you've hit on a very important point around this visceral fat. A lot of people, they don't realise the actual dangers that it can actually have. But the GLPs and the GIPs, they've actually been shown to reduce down the visceral fat. And I think that's really important, because although we have an issue with, say, for example, sarcopenia, which is muscle loss, or one of the possible side effects, one of the key areas is that it does promote the loss of this visceral fat.
Yes.
Would that be reasonable?
Yeah, that's true. Yeah.
Okay.
So Sharon, can we go back to talk about with non-drug activity for the moment? Because I would imagine there's two routes one can take here. If one is obese or one is overweight and one has problems with it, you have to go down the drug route, which we'll talk about in a moment. But pre-drug route, are there things that people can do?
There is, because obesity or overweight, because these drugs are used for both obesity and overweight.
Okay.
And just to, I think that's important, because obesity is a disease. And these drugs will be a lifetime treatment for the disease of obesity. So that's the same as if you have thyroid issue, you're on your L-toxin for life, or cardiovascular disease,
diabetes,
any chronic disease. Being overweight, these drugs are licensed, if you can see in here in our BMI chart. So being overweight is from 25 to 29.2. So these drugs would be licensed for overweight with one issue, with one health issue, such as high blood sugar, hypertension, joint pain. But these would not be a lifetime treatment for that. We would have diet and lifestyle first, because we have to think about the environment we live in. We're in such an obesogenic environment. We've got our highly processed foods, we've got our lack of activity, we've got our screen time, we've got, we just have so much convenience that we don't expend our energies.
So bottom line, lots of very rich food out there and not an awful lot of exercise to go with it.
Exactly, yeah. And if you think about, like, our biology has not changed, but our environment has.
Yes.
So years ago, we would all walk to school, cycle to school, we'd get to school, we'd play football, you come home from school, you'd go out doing jobs. Now, you get the bus to school or you get the car to school. You sit, you have your phone, you're on your device, you come home, you're on your device, you're on TV. You know, we're just not having the same environmental impacts.
Okay, so let's go to people now who might be listening to this at home. And by what you are saying and what James is saying, you're starting to ring bells. And people are saying, from listening to Sharon and James, I feel overweight, I might be obese, I'm listening to these two. What's that person's next move in your opinion?
Well, the first thing is to come in, to go to your GP or go to some medical person for advice, because all of this should be medically managed. So the BMI will be calculated, so based on where they are on the BMI and the EOSS. So let's say you're obese stage 4, then diet, lifestyle and medication straight away, and possibly bariatric surgery referral at that level. But if you're on the other level, where you're just overweight or obese stage 1, we'd always say diet and lifestyle first, because we say that for every chronic disease. If you have high cholesterol, it'll be diet and lifestyle first, let's recheck it. If that hasn't worked, then we go on to the statin. So it's the same approach with this, diet, lifestyle. So you sit down, you do a full interview with the patient, you get their physical activity history, you get them to do a food diary, you make out a dietary plan, and then if that hasn't ticked all the boxes, then we talk about medications.
Because is there a danger that people can be a bit lax about this? They say, oh, I'm a small little bit overweight, I'll go on a diet and I'll be grand. Do people tend to keep away from the medical professions when it comes to all things weight?
Well, I think that there might be a little bit of a weight bias sometimes in the medical profession, and that sometimes patients have a weight bias themselves. So it's something that they'd be saying, oh God, please don't check me weight when they come in for something else, like, you know. But I think it's something that's in all GP practices now. It's something that's been talked about a lot more.
Absolutely. And if the red flags are there, it's the old stitch in time saves 9 by going to a medical professional, be it down the diet, exercise route. First of all, that's given a period of time. If that doesn't work, then it's medical intervention or possibly at the end of the line, surgical intervention.
Yes.
Okay. James, do you want to go ahead?
I think purely what Sharon has said here, and it's so enlightening to see, is that from my practice as a pharmacist, I would see a lot of people coming in just getting the injection. And I think it's really, really important what Sharon hears. I know Sharon runs her own clinic, is that there's a guidance put in place to how it's managed going forward. Because I've seen people who have done so well on the medication, and then they decide to come off it, and within 6-8 months they're way back, even gained more weight. So that the need for education along with the injection is very, very important.
And James, are some patients making the decision themselves to come off it without medical assistance?
Exactly. Exactly. And
Deadly.
I've seen it before, that they lose the direction that they're actually going in, and they feel, well, I've lost weight now, I don't need to be on it. I think Sharon made such a valid point there today. Just like high blood pressure, just like your thyroid tablets, or there are particular cases where you need to be on this medication for life.
And Sharon,
that's where the value comes in.
Is that where the doctor also comes in? Is it the doctor that makes this decision?
It should be under medical supervision. Be it your doctor, your advanced nurse practitioner, but it needs to be under medical supervision. Because a lot of the time people are reaching out to the internet and getting medications that are
dodgy. Let's be honest about it. Now, before we go to the side effects, and we might leave that until after the break, James, can we talk about who qualifies for this and what about costs?
Yeah, well, they're very expensive medications.
Okay.
So one of the GLP-1s, Saxenda, does have reimbursement. It is the least favourable of them because it's a once a day as opposed to once a week, so patients don't typically like that.
By injection?
By injection.
Okay.
But this is very tight criteria for reimbursement. So you must have a BMI above 35, you must have cardiovascular risk factor, so it has to be either a high blood pressure on a 24-hour monitor, or it has to be elevated cholesterol, and you must have both an impaired fasting glucose and an elevated A1C. So it's quite tight criteria to get reimbursed for that. So anyone really that does get reimbursed for it they really need that medication.
Genuinely need it.
The other medications, the Wegovy is the GLP-1 that's licensed for obesity in Ireland. So you'd be looking in around the 160, 170 euros per month for that.
And who pays for that?
The patient.
The individual.
That, yeah, that's not reimbursed. Now, they have gone for reimbursement, but that could take a while.
That's a journey, yeah.
That's
a journey.
With the Department of Health. Yeah.
Is it? And is it a nightmare bureaucratically?
Well, I think ultimately, Jerry, the benefits of these particular medications, that if you're getting a healthier population out of it, it's going to reduce down the issues further down the line. I
see there's a lot of stuff coming in here now, so maybe we'll take our break, get our breath, and deal with some of the questions that are coming in, if that's okay, James. Okay, we'll do that now. So now we're doing our medical slot as always, the first Wednesday of the month, and today we're specialising on weight loss, the drugs for it, etc. And Sharon Egan is our advanced nurse practitioner. Between the two of us, Sharon, you're doing a wonderful job, by the way, because it's like being cross-examined. We talked about the costs of these drugs. Now, maybe before we deal with some questions, can we look at maybe some of the side effects? Because I'm sure with everything, these things have some side effects on certain situations with certain patients.
Yeah, well, I suppose initially they have the gastrointestinal side effects. So you've got everyone is different. So you may have nausea, you may have vomiting, you may have constipation or diarrhea. Some people report sulfur burps.
Are they very
which
stingy?
is quite distressing for patients, yeah. James mentioned the muscle wasting. So we do say to patients when they go on to these medications, because they can't forget to eat, so we tell them you have to prioritise your protein, you have to prioritise your fibre and your water, and we suggest 1.2 to 1.5 grams of protein per kilogram per day, which is quite a lot of protein.
Is it?
So, and again, we try to say make it real food. Like make it your chicken, your salmon, your Greek yogurts, not your protein powder, because that's again ultra processed. There's lots of ingredients in that. So you want clean foods, high protein, high fibre, lots of fluids.
Are there any people out there who, for whatever reason, absolutely cannot be prescribed these drugs?
It's contraindicated in medullary thyroid cancer. And that was based on a study that was done on rats, not humans. So it's very, very rare medullary thyroid cancer anyways.
Okay.
Rapid fat loss will cause or can cause gallstones, and gallstones can cause pancreatitis. So if you have pancreatitis, obviously you just have to stop the medication.
So while good and all as they are, it's clear that there is very strict medical supervision.
This should be under strict.
Dire warning, please keep away from the internet. Are you right? Would you agree, James?
Look, Jerry, as Sharon has mentioned here today, the benefits to be derived from these particular medications need guidance from the specialist, such as Sharon.
Yes,
And
absolutely.
this is very, very important. And purely on that basis, and that's where you'll actually get the benefit from. So over that period of time, whether it's a short period of time or a long period of time, as determined by the GP or the clinical nurse specialist, then ultimately that's where you're going to get the benefits, and your health will positively move forward from that by actually using one of these actual products.
Okay, can we deal with some questions now?
Absolutely.
Is that okay? If after having gastric sleeve surgery in 2023 and losing 9 stone to date, but find it just maintaining itself at this stage, I'm thinking of asking GP for a Ozempic or Mounjaro to try boost my weight loss further. Should I do this, as I feel my loss has started to neutralise too much? Thank you, says Nathan in Sligo.
Yeah, they're very successful. Both surgery and the medications are used in conjunction. So if there has been some weight gain post-operatively, then, it wouldn't be Ozempic now, it would be Wegovy, because that's licensed for weight loss, or Mounjaro, which is the dual agent.
Yes.
Yeah.
I'm just sorry to cut in there, Jared, just on that, you say you have the food sleeve put in, Sharon. Does that decrease this whole area of food noise that people, they're continuously thinking about food? Or is that where the benefit of the injection actually comes in, that actually helps remove that thought of food all the time?
I think the food sleeve is more the mechanical.
Okay.
And then the injections are more the biochemical, they're in your brain.
Gotcha.
With the
okay.
hormones.
So they can be used both together.
Yeah.
Okay, that's great.
Now, female, 60 years of age, I give up sugar and sweet things like cakes, biscuits, etc. I've lost 2 stone, that's 5 months ago. Eating food as normal besides, still off the sugar and cakes, but still losing weight. Never had diets or pills, is that normal? As I don't want to lose any more weight. How can I stay at the weight I am now and stay healthy? Any advice would be appreciated.
Yeah, well, just keep going, healthy exercise and healthy diet, yeah.
That's going very well.
Yeah.
That'll do the job. Now, I'm not so sure, but I'll put it out. Ask those experts if Irish Life Select More give back the consultation fee for my BMI in the north of Ireland. I'm in the south. Does that make sense?
I'm not sure about in the north of Ireland, no.
Okay,
Sure as well.
then we press on if that be the case. I have an underactive thyroid, so I was just wondering what foods to avoid gaining weight and maybe lose a couple of pounds. I try to avoid processed foods as much as possible.
I think if the person has an underactive thyroid, they need to actually make sure that they're on the correct dose of medication, because sometimes they need to get their blood tested, Jerry, to get the correct levels that they're actually meant to be on, because sometimes either by being on the incorrect level of medication can actually promote weight gain.
Okay.
So it would be important to make sure that they're on the correct medication and the correct dosing.
Perfect. Sharon, what advice would you give to an overweight lady who eats healthily enough, all home cooking, but who has awful cravings for sugar and bread after dinners?
Well, I suppose plenty of fluids, plenty of water with the dinner. I mean, if she's eating healthy and she's got no impaired health,
Plenty of fluids.
Plenty of fluids.
What's your view on fibre, Sharon? Is it like 20 years ago, probiotics were seen as new age, and now they're very much part of say proactive healthcare. Is there a need for greater talk around fibre?
I don't think we in society now have enough fibre.
Yeah.
We just don't. And same with gut health. I'm a great believer in Alpha-Rex or probiotics for the gut.
I would totally agree with that. In actual fact, they have shown that fibre, either soluble or insoluble, actually stimulates the production of GLP in the gut as well. Not to the level, obviously, that you'll be taking with your GLPs, but it's there. With
now,
fibre.
I suffer with weight all my life. I don't have diabetes or any other medical condition. Could I go on this medication for losing weight?
That's a bit subjective. They'd want to go into their medical practitioner, have their height, their weight, their waist
all checked out. Yeah.
And,
What's your opinion on GLP patches, moringa, and is it berberine advertised on social media continuously? Thank you, says Mary. I'm seeing a shaking
stay away
head.
from all of that.
See, it's internet, isn't it?
I agree,
yeah. I've just started a weight loss program with natural products from a company called Tranot, and they're amazing. I now have no cravings for anything sweet and feel fuller. I'm sleeping better, and it's so easy and safe to take. A drink in the morning before food and some digestive enzymes with food and sugar, transforming enzymes before you eat. I shredded over 5 pounds this past week. Totally safe to take. Are they asking for your opinion on that?
Well, obviously, it seems to be a statement, Ger, but I haven't actually heard of that myself, so I can't comment.
If it's a disease and classified as a disease, why aren't the government looking after all the costs?
Well, the government, that's the big question. The government are classifying obesity as a disease now, which is a huge win. We do have the semaglutide, as in the Saxenda, on reimbursement, which is a start. Wegovy and Mounjaro have both applied for reimbursement from the government. We do have also 4 tertiary centres around the country. So we've Loughlinstown Hospital in Dublin, we've got a hospital in Cork, we've got a hospital in Galway. They're bariatric centres. There's supposed to be up to 400 surgeries a year being performed. So the government, like, the framework is there. It is aligning, so we just have to...
Baby steps have been taken, essentially. Yeah. Okay. Have been on Ozempic for 18 months for obesity, and I've lost 6 stone. Had extreme side effects for a year and could only tolerate half dose. Stick with it. It's worth it in the end. That's kind of another statement, really, isn't it, about how some of the side effects can come.
I think it's important there, Jerry, as the patient has said there, they were taking half the dose. So that the dose sometimes need to fit the patient. Would that be reasonable, Sharon? You know, so the particular dose that the patient may need, Jerry, may actually need to be suited to what the patient is actually going to go through if they are going to have side effects.
Can you recommend a weight loss supplement that isn't a vaccination that you can get in a pharmacy off the shelf? What's happening there, James, with that question?
I don't know, Jerry.
No, I don't.
Just read out.
Can they recommend a weight loss supplement that isn't a vaccination that you can get in a pharmacy off the shelf?
I couldn't answer that, Sharon. You've never heard
I think they might mean that's not an injection, would they?
Yeah, that could well be the case, I'd say you're right, Sharon. So could something be recommended that isn't...
Mysamba.
Tablet form, is it?
It's a tablet form. Wegovy and Eli Lilly's Mounjaro both bringing out oral tablets.
Okay.
Not available yet. They won't be off the shelf either. They'll be prescribed. And actually, what was I talking about there? I was talking about we used to use it for smoking cessation, the Cymbalta. That is under Mysamba as the name of it, but that's under strict medical supervision. You have to actually do a checklist before you prescribe it, because it has been associated with suicidal ideations.
Wow.
So it wouldn't be off the shelf, no.
And it's tablet form, though?
Tablet
okay.
form,
Now, just a couple of things. The cost of good food is causing obesity. It's cheaper to get a trolley of cheap processed food and takeaways than good quality food. And that's the government's fault. Again, another statement. And I'm just listening to your show this morning. Protein is key. There needs to be more education about it and how basic meals with protein in it can be achieved. There's not enough information or education for people out there that don't understand this. Please educate people about protein. It's key and easy to get into simple meals. I've lost 12 kilograms in 12 weeks due to introducing protein into my diet and 10,000 steps a day. It's very easy and no medicine needed. That seems a lot of weight to lose in a short... That's, 26 pounds?
And that might be very easy for some, but it's not very easy for all. And again, just to bring it back to the disease of obesity, people living with that disease find it very difficult to lose weight.
Now, you did allude very much to protein, and James there a couple of minutes ago, and you emphasised and stressed how important that is. €20,000 to get bariatric surgery. If you don't have health insurance or well off as a family member, how can you work it? There are long waiting lists with the medical card holders, which is wrong.
And there is, I know some patients do utilise the HSC cross borders and go to other countries to have the surgery, which is done at a quicker pace, I suppose, and then when they come back it's reimbursable. Okay.
Now, we know how to make contact with James, but you have a practice yourself, Sharon, in Ball, is that right? And one to open in Charlestown,
yes,
is
well,
that?
I work in Ball with Dr. Elaine Broderick and Dr. James Broderick. I run the chronic disease management there, so obesity is just part of the chronic disease management programme there. But myself and Dr. Elaine Broderick again and Dr. Nettie Flannery are opening up a practice in hyperhealth in Charlestown. So hyperhealth is there in existence. It's unbelievable place in Charlestown. It's got hyperbaric chambers, it's got red light therapy. It is a very holistic facility. So we thought it would be just fitting for us to open up one day a week and to run a weight management clinic down there.
So this facility is there now in Charlestown?
They're now up and running, yeah.
Wow. And you can give the injections, can't you? As in the injections can be given there on the day and prescribed there. And I think that's a because ultimately, Jerry, what we're talking about here, and I'm sure you can see, from my perspective, we would give out a lot of Wegovy, Manjaro. But I think what Sharon has brought here today is the importance of education and understanding of, where I am with my BMI and how I'm going to manage this going forward. And the difference between weight loss and obesity. Sharon, I know Practitioner will be crammed with calls asking about you, where they can contact you. So what can we say about that? How can you be contactable?
I can be contactable. We have our web page, and we have a Facebook and an Instagram. So it's aesthetics at hyperhealth.
So we leave that with Practitioner on the way. Aesthetics at hyperhealth.ie. Can someone with diverticulitis and osteoarthritis go on the slimming injections?
They can. Somebody with diverticulitis may have some GI upsets. You see, we don't know what GI upset you'll get. So if it was constipation or diarrhoea, it might not be a fit with the diverticulitis. But we do have patients on it. Well,
Sharon, you've certainly opened a door and answered lots of questions. It's been great to have you in. It's, I know, your first time to do it. It won't be your last, James, we believe. Because you have other specialities and we'll deal with those as we go along. James, that's about it for today.
That is absolutely fantastic. And can I just say a big thank you to Sharon coming in today, because it's been so opening for me, both from an educational point of view and an observational point of view as well. Thank you so much.
It's been enlightening. Thank you. So we'll leave your details with Practitioner for people who need to contact you, Sharon. And James, as always, malloyspharmacy.com.
Yep.
And 096 60072.
Absolutely.
If people need, and you'll be back doing some regular questions, if I can put it like that, next month.
Absolutely.
Thanks a million. Thank you, James. Thank you, Sharon, for coming in. Thank you, Practitioner, for working in the programme. And indeed to all who have been involved for all the questions, and to our friends at Harrington's who make it possible.